Yes, madam, you can start now.
Okay. A very good afternoon, everyone. Myself, Dr. Preeti Shankar, Vice President of Federation of Family Physicians of India, FFPI, take pleasure in inviting you all, welcoming you all to today's webinar on anemia. I welcome our President of FFPI, the dynamic, young, energetic, and very active Dr. Pragnesh Shah. I welcome our renowned speaker, Dr. Mahadev Desai, Dr. Neha Goel, and Dr. Sanjay Shah, who will be moderating the session. And last but not the least, all you delegates, friends, and colleagues who have joined us today. I request Dr. Pragnesh Shah to say a few words about FFPI and its activities. Over to Dr. Pragnesh.
Thank you, madam. Federation of Family Physicians Association of India, as we all know, that is established since 1986, and very shortly, it means from the next week, we are organizing a webinar with Dr. Tushar Sir, renowned speaker from Mumbai, a series of webinar back to basic on every once a month. And for that, I am a College of General Practitioners and Academy of Family Physicians of India is also join hands with us. So we are thankful to both the association. And now, not wasting much more time, I request our speaker, Dr. Mahadev sir, to take a charge. Dr. Mahadev sir, please.
Thank you, Dr. Pragnesh. I request Dr. Sanjay Shah to introduce our today's speaker and take over the proceedings. Over to Dr. Sanjay.
Yeah. Welcome all the delegates. I welcome all of you for our first webinar on anemia by FFPI, and our speaker is Dr. Mahadev Desai. It will be my pride to introduce him. Dr. Mahadev Desai is presently working at KD Hospital City Center, Vastrapur, Ahmedabad as senior consultant physician. Doctors of Ahmedabad, most of them are knowing Dr. Mahadev Desai. He did his MBBS and MD from MS University, Baroda, served at medical colleges of Gujarat at Baroda, Surat and Ahmedabad, and having 40 years of teaching and professional experience. He was honorary editor of Gujarat Medical Journal in 1999 and 2000 and awarded Dr. B.N. Mehta Oration by AMA in 2012 and awarded Dr. N.H. Patel and Dr. Rasiklal Shah Oration Award by Association of Physicians of Gujarat in 2018. After listening to Dr. Mahadev Bhai, everybody will appreciate that he is a very good teacher, and we teach lifestyle disease by Dr. Mahadev Desai in our HCG Institute, and many of us have attended that series. And today, Dr. Mahadev Desai will talk on the topic anemia. Anemia is a very common topic in our practice, and quite a time it is difficult to differentiate different types of anemia. And similarly, in treatment also we have to be careful in giving treatment. So today it will be our pride to listen Dr. Mahadev Bhai, and I welcome Dr. Mahadev Bhai to have his talk. Welcome.
Sir, you are mute. Sir, you are mute.
Mahadev Bhai, you are mute.
Hello. Am I audible?
Yes, sir.
Are my slides visible? Are my
Yes,
slides
sir.
visible?
Yeah, visible.
Yes,
Yeah.
sir.
Yeah.
Good evening and thank you very much, Dr. Pragnesh Bhai, Dr. Preeti Madam, Dr. Sanjay, and all the office bearers of the Family Physicians Association. It's my pleasure to be with you this afternoon. And this is a topic which is very dear to me. And I'm going to talk about more of the practical aspects of anemia. Before that, just a slide about what we do for all the doctors in India across with an app called Medflix. This is doctors only app, and wherein I, Dr. Tushar Shah, who is going to start the next series, they're all regularly contributing to the different topics, and it's always in the evening hours. And as for example, this is the topic that we are going to discuss today on our platform, that is a diagnosis and managing alcohol use disorder by Dr. Himanshu Desai. He is a renowned uh, psychiatrist at Ahmedabad. Then we have got another topic in line tomorrow, that is bleeding manifestations by Dr. Baldev Prajapati. He is a renowned pediatrician. Then we have also got the wizards of medicine, that is the emergency medicine quiz. And everybody, all medical persons can join and even participate in all these programs free of cost. So I humbly request you that please take advantage of all these experts. Now, coming to today's topic, before that, my disclaimers. I am not neither a hematologist nor a pathologist, and anemia is too broad a topic to be completed in 40-45 minutes. The normal values that I'm going to mention differ from laboratory to laboratory and textbooks to textbook. So please interpret according to the laboratories that you are referred to. Now, the most important part are these generalizations, that what I've learned over the years for treating anemia, that if somebody say that he has anemia or if you're diagnosed anemia, it's an incomplete diagnosis. Anemia can have more than one cause and more than one type in a given patient. Always keep in mind the chronic kidney disease and chronic liver disease as one of the possible etiology in any patient who are having anemia. Then most untreated anemias are the mild anemias. We generally tend to neglect anemias of 11.5 gram. We don't try to look for the cause for that anemia, and they suffer the most. Anybody would be very alert in looking for the cause and all investigations for a hemoglobin of 5 or 6. But for 11.5, we tend to say that this is okay, normal. That's not correct. Then most of our patients have combined deficiencies of iron, B12, folic acid. Never ever start treatment without confirming your diagnosis, because one tablets of B complex or one tablet of iron can change the RBC pictures or the laboratory pictures, and then you have your own confusions. Blood transfusion as treatment of anemia is very selected cases. IV iron is underutilized treatment for iron deficiency anemia and is very safe, especially the newer iron parental molecules that are available. And transparent saturation is the most sensitive parameter for iron deficiency. It is neither serum ferritin or serum iron. Having said this, let's start with the case. Here is a female of 30 years from poor socioeconomic status. She presented with a complaint of fatigue, breathlessness on exertion, lethargy, menorrhagia, weight gain, constipations, all for 4 months of durations. On examination, she has brittle hairs, her pulse is 60 per minute, she has marked anemia, she has koilonychia, she has non-pitting edema on her legs, and on cardiovascular system examination, she has systolic murmur. So at first, obviously, she has iron deficiency anemia because of the clubbing, I mean the koilonychia. But is there any other disease suggested? We can at least ask the members on the floor, do you suspect anything else other than only the poor economic status and menorrhagia as the cause of anemia?
Hypothyroid?
Yes, very good. So it's very important that look for the cause of anemia. As I said, menorrhagia, anybody would say that, yeah, menorrhagia can lead to blood loss and anemia. But unless we treat hypothyroidism, if we give tons of iron in her menorrhagia or anemia is not going to be corrected. And see, there are certain features like weight gain. If she is from a poor socioeconomic status, why should she be having weight gain? Then her pulse is only 60 per minute. In anemic patients, we expect pulse to be on the higher side. Then koilonychia suggests chronic iron deficiency anemia. If somebody develops iron deficiency because of a 1 week or 2 weeks of blood loss, there wouldn't be koilonychia. So it's a chronic iron deficiency anemia. The point is, as you rightly said, that she has hypothyroidism. In fact, when we were in the teaching hospitals, we canceled so many of the hysterectomy because we were referred for the pre-operative checkup, and we found out that the lady is suffering from hypothyroidism. and see her most of the symptoms disappear by treating the hypothyroidism. Case 2, here is a gentleman, 67 years. He is a known patient of ischemic heart disease. He also had hemorrhoids. He has been receiving aspirin, metoprolol, and hematinics. He presented with fatigue, weakness, breathlessness on exertion, and constipation. And he also complained of melena, which was doubtful, and weight loss of 6 kg in 4 months. He also has presented with 60 pulse rate and anemia and clubbing of fingers. This time instead of the koilonychia, he has bilateral pitting edema, tender hepatomegaly, systolic murmur. So, any thoughts? What else other than anemia this patient has?
COPD.
Right, madam. Anything else? See, the patient who has got the pulse of 60, here we can explain by metoprolol. Melina, we are not sure whether it is because of the aspirin or because of these on hematinics or there is an actual blood loss. Yes, because his weight loss is 6 kg in 40 months, he is 67 years. At least we keep in mind clubbing of fingers, anemia, weight loss. So always keep in mind. And also, of course, he has got anemia leading to heart failure because he has got systolic murmur, hepatomegaly, and pitting edema. So the point is, whenever we have a patient of anemia, it's not only our duty to find out the cause of anemia, but we have to treat that cause also, and we should look for multiple causes. So, with this introduction, let us see how I'm going to deal with definitions, common causes, classifications, important points in the history in clinical examinations. First investigations, first set of investigations, and other investigations. So, what is anemia? By definitions, anemia is reduction in hemoglobin or hematocrit or RBC count. So all, whether the hemoglobin or RBC mass or the packed cell volumes, any of these, if they are reduced, it's anemia. The normal hemoglobin concentration, again, as I said, varies from book to book and laboratory to laboratory. So male, generally it is 13.5 to 17 grams and female it is 12.5 to 16 grams. But WHO defines anemia as males having less than 13 gram and females having less than 12 gram. If we talk of normal RBC count, in males it is 4 to 6 millions per cubic millimeter of blood, and for female it is 3.5 to 5 milliliters of blood. It's very important to remember one, that is the rule of 3. That means whenever you see the hemoglobin, if you multiply by 3, you get hematocrit or what is called packed cell volume. Hemoglobin is more important packed cell volume because hemoglobin is what we measure. Packed cell volume is what we calculate. So always remember this. Try to find out the hemoglobin and multiply by 3. That gives us packed cell volume. In males, it is less than 14 and female, it is less than 36. We'll be talking about the hematocrit or packed cell volume in a minute's time. Very importantly, whenever we see a blood report, we have to keep in mind, could this be a false high or false low? We know there are so many times the hemoglobin is on the lower side, but the patient may not be anemic. A classical example is pregnancy. We know that in pregnancy there is increase in the RBC mass as well as increase in the plasma volume. So it is basically a dilutional anemia, or we can say that depending on the stage of the pregnancy, the anemia can label only when we have got the hemoglobin of less than 11 in the first trimester or less than 10.5 in the second or third trimester. We should label that woman as having anemia. Likewise, if the patient received multiple transfusions, there is going to be false low hemoglobin. And conversely, if the patient is a smoker, we know that smokers, persons living in the high altitude, they all have high hemoglobin because of the reasons that we may discuss later. But important is hemoconcentration. We know that the common diseases that we face in the epidemic is the dengue. In dengue, we'll get always hemoglobin on the higher side. Anybody who comes to me with the high grade fever and a hemoglobin of 14, right? And if his hemoglobin before a week or before 10 days were 13, I would always think that this is hemoconcentration and will be on high alert. So hemoconcentration is something we should always keep in mind. So are the other features. Now, first, I usually approach any patient, right? In all my practices. First, we define the problem. We have defined what is anemia, right? Now we look for some of the common causes. If we know what we are dealing with and we know what are the possible causes, probably it becomes easier to look for when we see a patient. So what causes anemia? We know that anemia can be because of the increased RBC loss or RBC destructions, or there can be decreased RBC productions, or there can be increased requirements. Increased requirement, is a very simple things, pregnancy, lactation, or childhood or puberty. But what causes loss of RBCs or destructions? Remember 3H: hemorrhage, blood loss anywhere, hemolysis, whether it is malaria, G6PD deficiency, or many other like prosthetic valve, autoimmune hemolytic anemia, hemolytic uremic syndrome. So hemorrhage, hemolysis, or hypersplenism. Patients with chronic liver disease, portal hypertension, they have a big spleen, and the spleen itself work as a villain and produce lots of anemia and other cytopenia. Then decrease RBC productions. RBCs need so many substrate, right, and so many hormones to control their production. So if there is lack of nutrients like deficiency of iron, B12, folic acid, will have definitely anemia. Bone marrow either is suppressed or it's because of some infiltration of the bone marrow. So aplastic anemia, marrow infiltration, bone marrow suppression because of the drugs, chemotherapy, irradiations. Low levels of hormones like erythropoietin or thyroid hormones, they all can lead to decreased production and subsequent anemia. And increased requirement, we already said. So if we have at the back of the mind any patient who presents with anemia, first and foremost thing, always try to look for, is it because of some obvious blood loss or hemolysis? Or is it because of the deficiencies of the substrate or deficiency of the hormones that is required to regulate? Or is it a simple case of increased requirements? Now, symptoms. We know that anemia is one disease where the symptoms are very, very vague. And there is no one particular symptom which can be attributed to anemia, or anemia cannot be the only diagnosis when patient presents with some of the symptoms. Is it fatigue, lethargy, irritability, headache, shortness of breath, reduced exercise tolerance, paresthesia, restless leg syndrome, feverishness, pica, or pagophagia? I'm coming to a few of them, right? Hematuria or dark urine, chest pain or precipitation of the angina, or syncope. So these are the symptoms. I have listed few, but virtually anemia can present with so many other symptoms, right? It can be edema also if it is also hypoproteinemia or culminating to heart failure. So pica is something that patient gives history of eating a food which is eating something which is not a food, or when the patient is a craving for ice, that is called pagophagia. So always remember, but it's sometimes we feel that it's because that patient is eating this, he's getting anemia. That's not the case. It's usually required to be known because we can treat it, and there may be sometimes the psychological reason for having all these kind of perverted habits. But pica and pagophagia we need to keep in mind. Now, whenever we see a patient of anemia, at least we should spare few minutes. I know it's very difficult for me to understand the number of patients that the family physician is looking for, but this need not be looked on the very same day, and you are in the good place where you can see the patient number of times, and or you may have seen the patients for a long time, so you can, some of the symptoms or the findings you can make out more easily than we as consultants. We hardly see patients once in first time, and then maybe another 3 months or 4 months down the line, but you have the luxury of seeing the patients more often. So whenever you see a patient with anemia, you can always find out whether there is an acute onset or a gradual onset of anemia in this particular patient. So we always straight away ask whether there is any history of blood loss, whether it's a trauma, piles, menorrhagia, hemoptysis, hematemesis, hematuria, any of this. Then chronic anemia is usually because of the chronic blood loss or worm infestations, nutritional or bone marrow failure. Then whether there is any history of weight loss, that's very, very important. Patients having weight loss, joint pain, and all going on for a long time. We know we are dealing with something like the collagen diseases. Then bowel disturbances, steatorrhea, abdominal pain, they all lead to malnutrition and the malabsorption. Dietary habits, we already talked about. Then some of the habits, like the patient might eating everything, all balanced diet, but they're eating all together, and that could be the reasons that he's not having a good hemoglobin. Always inquire about the drugs. Patients may or may not tell us about all the drugs that he has been taking, including the non-allopathic drugs or the alternative medicines. So many of patients are receiving so many Ayurvedic products and homeopathic products, but they may not feel like telling us. But it's very important to know. We know that the chronic liver disease and chronic kidney disease so often are because of this alternative treatment. Methotrexate is one drug we have to keep in mind, right? Then whether the patient had undergone bariatric surgery. We know that bariatric surgery is responsible for so many of the malabsorption of iron, calcium, and so many other nutrients. Then, obviously, in patients who are female, always inquire in the menstrual age, always inquire about menstrual history as well as the obstetric history. Occupational history is important, whether the patient has been exposed to any toxins or benzene or aniline. Then, family history of anemia. There are families where anemia runs in families and generations, whether it is a hemolytic hemoglobinopathies like thalassemia, sickle cell anemia. If there is, we have patients where all members have got splenomegaly, have got jaundice, and it's an autosomal recessive disease. So many members are affected. And just by diagnosis, a condition like hereditary spherocytosis and subjective dermatosplenectomy, they're all cured. So this is what is important. Whenever we see a patient who has anemia, but no history of blood loss, it need not be acute, whether it's acute or chronic. If the patient has no history of blood loss or any drugs incrementing the anemia, keep in mind hemolysis. Because hemolytic anemia is something we have to think of or suspect and investigate. So any patient who has history of dark color urine or cola colored urine, any patient who has got jaundice, but his urine is not yellow, patient who had history of gallstones, patients who had undergone prosthetic valve surgery, patients who had undergone blood transfusion recently, any persons having some symptoms which could be attributed to the collagen diseases like rheumatoid arthritis, systemic lupus erythematosus, family history of again anemia and jaundice in many members, or they have been told to avoid certain drugs. Some of the communities where we know that certain anemias like G6PD deficiencies are so common. So this is something will lead us to investigate for hemolytic anemia. Physical examination is very, very important and make you many clues about the type of anemia or cause of anemia. Like if there is conjunctiva or nails are pale, but if the crease is also the palm crease are pale, we know that anemia is significant, right? Otherwise, we do not expect the anemia, the palm crease to go pale. So very important. Koilonychia clubbing, we already mentioned. Then pigmentation over the knuckles. This is something we can always look for when we ask the patient to show his hands, right? If there are pigmentations of the knuckles like this, right, we always keep in mind the megaloblastic anemia or vitamin B12 or folic acid deficiency. It's very important to remember certain conditions like acanthosis nigricans also give pigmentations, right? But that's usually the pigmentations are also seen over the neck or in the armpits. But keep in mind at least the megaloblastic anemia when the patient has got pigmentations. Likewise, if there are pigmentations over the angle of the mouth or if there is a red, painful tongue, we always think of B complex deficiencies. Then, if the patient has Patechi purpura, always we keep in mind something like idiopathic thrombocytopenic purpura or dengue these days. Jaundice, as we said, we always look for the hemolytic anemia as one of the cause and always inquire about the color of the urine and color of the stool. If the patient is urine is yellow, stool is yellow, and sclera is yellow, probably we are dealing with either hepatocellular or obstructive jaundice. But if the urine is not yellow but dark colored, maybe high colored, right, or cola colored, and the stool is regular color, probably we are dealing with hemolytic anemia. Lymph node enlargement has to be looked for in the neck as well as we also look for the hepatosplenomegaly. And if the patient has a typical facial features like the frontal bossing or malar prominence, what is called a chipmunk faces, we know that this patient is having anemia for a long time and it's because of the expansion of the bone marrow. That's because of usually the thalassemia. Then never forget to look for the splenomegaly and hepatomegaly. And if the patient has murmur or whether the patient has peculiar sounds, if they has undergone valve replacements, and whether there are any signs of heart failure like the third heart sound or fourth heart sound or crepitations in the respiratory systems. neck veins engorgement, etc. And if the patient has complained of typical burning paresthesia, we also look for the signs of neuropathy. So the point is, in the general examinations, we may be able to pick up some of the types of anemia. Koilonychia is always chronic iron deficiency anemia. As I said, if the patient has acute anemia, even though it is iron deficiency, we may not look for we may not get koilonychia. Then investigations are very, very important, but there is a list of investigations, and it is neither practical nor affordable on to our patients for going for the battery of investigations. So I would say at least go for these 4 investigations to begin with. That's why we have mentioned even in the list of the talk that I am going to talk, the contents, that we'll first get the initial investigation. So order for CBC. Now, when we write complete blood count, it may mean different for different laboratories and pathologies. So always specify that you want hemoglobin total count, differential count, peripheral smear, RBC indices, and ESR or erythrocyte sedimentation rate. What is important, not totally order, is reticulocyte count. It's very, very important investigations. This is one investigation we must ask for at the very first meeting, because once we give a drug hematinic, probably the reticulocyte count will start rising if the patient has some deficiencies of this substrate. So always go for reticulocyte count. And now in most of the laboratories which use automated counters, even the reticulocyte count, they all come right on its own. So we don't have to even ask for it. Only thing we have to look for it. So get CBC, ESR, peripheral smear, RBC indices, retic count, urine analysis. So many times we pick up microscopic hematuria, proteinuria, cast, etc., to point to the kidney as a cause for culprit for the anemia. So always look for urine analysis. Stool examinations, obviously, let's say we can always pick up occult blood, we can always pick up the worms. And for occult blood, it need not be only one single set of examinations. We should go for ideally minimum 2 to 3 consecutive days stool examinations. So these are the basic investigations. I would be concentrating more on the peripheral smear and the RBC indices, because that is what we can do it, and we get so much of information from these 2 investigations that we'll be sparing little more time on that. So hemoglobin count, we'll see later, but WCs are equally important when we are looking at the cause of anemia, because many times we can pick up the cause of anemia in WBC count report. Like if the patient has infections, patient has leukemia, peripheral smear itself might give the point presence of blast cells. If the patient has so many hyper segmented neutrophils, normally we don't expect the neutrophils to have more than 5 lobes in a neutrophil, right? In a routine person or a normal person's, if there are more than 3% of the neutrophils showing more than 5 lobes of neutrophils, right? Then it suggests hypersegmented neutrophil, which is an indirect evidence of the megaloblastic anemia. Platelet counts, we know anemia can have platelet counts with a normal platelet count, low platelet count, or high platelet count, and it has its own interpretations. Normally, when the patient has iron deficiency anemia and other reports are normal, we expect platelet count to be slightly on the higher side, because if the patient start receiving the hematinics, right, then the bone marrow start would respond, and that response will be also in the form of increased platelet count. So low hemoglobin with high platelet count is more in favor of a functioning bone marrow and probably some deficiency of the substrate like iron deficiency. If WBC, platelet, and hemoglobin, all 3 are down, or only 2 of them are down, we call it bicytopenia or pancytopenia, then obviously we'll look for cause like something to do with the either bone marrow, or maybe there's a hematological disease we are dealing with, or maybe something like myelodysplastic syndrome. Not a very common condition, but we keep at the back of the mind. ESR again, normal, very high, and low. We know about the very high ESR and normal ESR. The ESR, again, the laboratories give so different readings that most of the patients will come and complain, my ESR is very high, it is 22. And if the patient is 60 years. Usually the patient who 50% of his age may be cut off, said as the cutoff limit for the ESR, right? So if the patient is 60 years, 30 millimeters at the end of the first hour should be seen as normal. we are interested if the ESR is very high in the range of 80s, 90s, and 100s, then we always look for collagen disease or malignancy or something like multiple myeloma, those kind of diseases. If the ESR is very low, sometimes we find 0, 1, 2, and we had patients where we thought of disease like sickle cell anemia because of the low ESR. So patient complaining of joint pain and ESR was 1 and his hemoglobin was 10, and we insisted with the pathologist, look for the peripheral smear, and we could pick up something like sickle cell anemia. So low ESR, high ESR, very important. Peripheral smear is the most important investigations, right, for anemia. I would say it's as important as ECG for a patient complaining of chest pain, right? But probably give more information than that. That look for the size of the RBC. When we see a peripheral smear, right, we always compare with the lymphocyte, small lymphocyte, nucleus of the small lymphocyte. We know that lymphocyte has hardly any cytoplasm. So practically, small lymphocyte size is what is expected to have normal RBC size. Any RBC that we see in the peripheral smear, smaller than that are called microcytic. Any RBC or most RBCs bigger than the small lymphocytes are macrocytic, because we don't have any compass measurement to see whether it is 7.2 or 10 or 11 micron. So we always look at the lymphocyte, small lymphocyte, and compare and say whether it is microcytic or macrocytic. Size of the RBCs is called anisocytosis. Microcytic, the most common obviously is iron deficiency, but also is thalassemia. Then macrocytic, bigger RBCs, we always keep in mind vitamin B12 and folic acid. Patients who has partial treatment, we might feed the mixed pictures of some microcytes, some macrocytes, right? So always keep that in mind. Then shape of the RBC, very, very important. We know that RBCs are rounded on the peripheral smear, even though in real life they are having a deformability and they can bend and they pass through a capillary which is smaller than its diameter, microcapillary. So they are deformable, and that is the most important characteristic of RBC. But some of the RBCs like sickle or spherocytes, they cannot bend, they cannot pass through small capillaries because of their shape, and that is why they produce hemolysis. So spherocytosis will be showing in a slide what is spherocyte, what is ovelocyte. These are all different shapes. These are called poikilocytosis. So anisocytosis is size variations. Poikilocytosis is shape variations. They are equally important, give a lot of information. We also look for something like teardrop cells or whether there is any helmet cells, and so many. We have slides for that. Then parasites, always we have to insist with the pathologist that patient is having fever and anemia or recurrent fever and anemia. So please look for any parasites that we can look for. The most important we know is malaria. So this is the normal peripheral smear of a normal persons with a normal hemoglobin. We can see the RBCs are rounded and there is a central pallor. Usually it's a 1/3 of the diameter is pale, and this is normal. If this 1/3 pallor has increased, we call it hypochromia. If this 1/3 is reduced, right, we call it hyperchromia. And this is what we expect in a spherocyte when there is no central pallor. So normal RBCs, hypochromic RBCs if the central pallor has increased, and hyperchromia if the central pallor has disappeared totally. So this is obviously hypochromic microcytic RBCs, because this is the WBC for comparisons. So this is a typical iron deficiency anemia picture. As against that, we can see multiple sickle shaped, right, and small RBCs. This is typical sickle cell anemia. This is iron deficiency. This is a normal picture. And here we find so many of the RBCs which are where the central pallor has disappeared and they are all rounded. This is typical spherocytosis. If we find this picture, I don't think we need any investigation for this patient for the diagnosis, because the diagnosis is very much written here. Straight away we go for the treatment. Then this is very, very important. Whenever the patient has got the abnormal cells, it is the smart pathologists who pick up and say that look for some microangiopathic hemolytic anemia. Whether he say that I find so many cells which are either the vacuole cells or maybe the blister cells, the RBCs which has got a central part which is either like a bite cells or a blister cell, all abnormal kinds of RBCs, whether their RBC shape is different with multiple spikes, which is called the acanthocytes, they all can be seen in patients with hemolytic anemias, especially the microangiopathic hemolytic anemia called hemolytic uremic syndrome. This is one condition which is quite serious, and most of the time the points come from the pathologist, right? Especially the thrombotic thrombocytopenic purpura, which is a very serious disease where patient has got anemia, bleeding tendency, thrombotic tendencies, and neurological picture. So when you in doubt, patients with anemia always discuss with pathologists about the whether he can look for any of these. So these are the helmet cells. Again, fragmented RBCs, abnormal shapes of the RBCs. These are all microangiopathic hemolytic anemia. Not very common, but not uncommon either. Then we come to the RBC indices. We know packed cell volume or hematocrit, that is the proportion of volume that is occupied by RBCs. So we know that 45% is a normal we are talking of, and female is 38 to 40. Less than 41 or less than 36 is generally considered as anemia. Mean corpuscular volume is very, very important, and that can be calculated from the packed cell volume or hematocrit into 10 upon RBCs, right? It's measured in femtoliters. Then MCHC is the amount of hemoglobin relative to the size of RBCs, right? If it is MCHC is less, it is microcytic. If it is very high, it is phagocytosis. And RDW, it's a new index, and this is possible only with the automated cell counters, which most of the laboratories are using. And this is practically same as what we see in N-icytosis in peripheral smear. You find different shapes of the RBC, size of the RBC. Some are small, are big. If you look for RDW, it is same thing. If you have got few RBCs which are smaller, if few RBCs which are bigger, normally in a normal persons, the RBC volume remains almost same. So the RDW, that is the red cell distribution width, is 12 to 15. If the patient has RDW of 16, 17, 18, that means that person has number of RBCs which are of different sizes. Some are small, some are big. And that indicates that probably this patient has got deficiencies of either iron or B12. So high RDW helps us in suspecting deficiency anemia like B12 or iron, while normal RDW with microcytosis, right, and low hemoglobin, high RBCs always point to thalassemia. We'll come to that later also. Remember, RDW is very, very important when you are in doubt whether it's iron deficiency, thalassemia. That is where it helps. But the most important value parameter to me, as far as the RBC indices are concerned, are the MCV, or which is called mean corpuscular volume. The normal RBC size varies from 78 to 100 femtoliters. Again, different books will give different. Many of the books would say 80 to 100. That's fine. 78 or 80. So this is normal. Anything less than 78 or 80 is microcytic. Anything more than 100, some books mention 95, is bigger, is macrocytic. So whenever we see a RBC indices and a patient has anemia, always first try to find out whether we are dealing with normocytic anemia, microcytic anemia, or macrocytic anemia. And depending on that, our differential diagnosis now is narrowed down. If you are dealing with normocytic anemia, any acute blood loss, any patient has drug-induced medications, or chronic disease or chronic infections, usually have normocytic anemia. Again, there is some overlapping between normocytic and microcytic. Patients with chronic disease and infections can have microcytic or normocytic. But most common cause of microcytic anemia is iron deficiency and thalassemia. Lead poisoning, sideroblastic are not very common, but worth keeping in mind when we ruled out iron deficiency, thalassemia, right? Or if there is some suspicion of the patient has been taking certain Ayurvedic medicines, right? It could be lead poisoning, or smart pathologists say that there is some basophilic stippling. We keep in mind this, right? Macrocytic anemia is divided into megaloblastic and non-megaloblastic anemia. Megaloblastic is vitamin B12 and folate deficiency, while non-megaloblastic equally important if the patient is receiving certain chemotherapy, patient has chronic liver disease, hypothyroidism, or patient has simple hemolytic anemia and there is increased reticulocytes and that lead to high RBCs because reticulocyte counts are bigger than the normal RBCs. Reticulocytes are a stage ahead of RBC in its maturation. Reticulocytes are something which are usually in the bone marrow. Hardly 1% is seen in the peripheral smear. But if the patient has more number of reticulocytes, the automated counter doesn't differentiate between these two. Automated counter is told to see the only size of the RBC. So increased reticulocytes would always give a macrocytic anemia, worth keeping in mind. So that is what the reticulocyte count is. Very, very important investigations. If you have got after CBC, if you have got MCV and retic count, probably we have the diagnosis of the anemia in most of the patients, right? We know it's a stage in the RBC development before the mature RBC. RBCs are not nucleated cells, right? And that all that we see are the DNA. The DNA material which can be stained by specialized stains, brilliant crescent blue, that will give a typical chromatin network and that can pick up the peripherals in the peripherals here, reticulocytes. Normally, 1% RBCs are cleared daily because RBCs we know has a lifespan of around 120 days. So what we expect normal retic count to be between 0.5 to 1.5, but we have to correct it. We can say the corrected retic count is very, very important. But before that, whenever the retic count is decreased, whenever the reticulocyte count is reduced, always keep in mind it is because of the commonest is iron deficiency anemia, aplastic anemia, chronic infection. So patient having anemia and decreased retic count, I always think of first as iron deficiency anemia. Patient who has got anemia with increased retic count, straight away one of the three H again. Either the patient is losing blood somewhere, patient is having an RBC destruction somewhere, or he has been treated partially by drugs and that is why the bone marrow is responding now that he had deficiency and is being corrected. So increased retic count is very, very important. So is important decreased count. Whenever you are suspecting whether we are dealing with iron deficiency or not, go for retic count. So retic count is very important, but it's important before you give a tablet of iron or B12 because that will change the picture. A patient has iron deficiency anemia, you give hematinics, presuming that whether it's iron or B12, give iron B12 both and you should be fine. That's not how we should treat anemia. And this is a corrected retic count that you see what is the patient's retic count and look for the patient's hematocrit, divide by the normal hematocrit, right? For normal, for male, it is 45. For women, it is 40. If the corrected retic count is more than 2, corrected retic count again is more than 2, more than the normal values, it's suggestive hemolysis or blood loss. Straight away look for some cause of blood loss. If there is no obvious blood loss, right, after history, all that you look for is the stool examinations, right? Then rule out hemolysis. But if the retic count is low, always think of some hypoproliferative. That means the bone marrow is not responding because of the some deficiencies, either iron deficiency or erythropoietin, hypothyroidism, something like that. So patient has anemia, look for the retic count. If the retic count is more than 2%, hyperproliferative, less than 2%, hypoproliferative. Hyperproliferative, we say that most important is blood loss or hemolysis. But if the retic count is less than 2%, that is bone marrow is not responding. That is either with low MCV, normal MCV or high MCV. We already said this, look for, right? Iron deficiency, thalassemia, chronic iron deficiency anemia, high MCV is B12, chronic liver disease and all. And normal MCV is chronic kidney disease, chronic disease or infections, bone marrow abnormality or endocrine disease like hypothyroidism. So very importantly, after anemia, all that we need is retic count. And depending on that, we can look for whether the retic count is less or more. If it is more, we'll see later. Okay, well, talking about the low MCV, that is if there is low MCV, we know there are three important conditions: iron deficiency, chronic anemia, and thalassemia. These are probably the most commonly encountered anemia in our practice. Iron deficiency. Now, what investigation we should go for? We should go for serum ferritin, transferrin saturation, serum iron, serum iron binding capacity. Most laboratories do not do transparent saturation. To me, this is one of the most important investigations, and the value of 20 is very, very important. Patient has transparent saturation less than 20%, right? And microcytic anemia, you can say that it is iron deficiency anemia. Serum ferritin, serum iron, they are all acute phase reactant. In any infections, inflammations, they can go up in spite of the patient having actual iron deficiency anemia. After all, serum ferritin is a iron storage. So also phase reactant. So any patient having any inflammations, infections, it can go up, though we can be under wrong impression that because the ferritin is very high, it's not iron deficiency. So look for transparent saturations always. If the transparent saturation is very high, more than 40%, probably we are dealing with iron overload. Keep that in mind. Menzer index is very, very important and very handy. The pathologists usually give this again more for thalassemia. More for thalassemia. What is Menzer index? Menzer index is just MCV upon RBC count. MCV upon RBC count. RBC count is 4 on the MCV is 20. Then we know that it is 20. So that's different. But thalassemia, we always look for Menzer index to be very low. Or in short, if you can say practice, in iron deficiency anemia, the MCVs be usually around 70, 72, 68. But in thalassemia, usually the MCV is in 60s, 56, 60, 62, 64. If somebody has the MC value of 60, 62, I would always be looking for thalassemia. If the patient has RBC count near normal, RBC count, we have already said 3.5 to 5 millions per cubic millimeter. If the RBC count is, say, around 4 cubic millimeter, hemoglobin is 10. We don't expect for a hemoglobin of 10 to have an RBC count of 4 or 4.5. And his MCV is 60. There is hardly anything to look for. It is thalassemia, whether it is thalassemia, beta thalassemia or alpha thalassemia. For beta thalassemia, we have a test, thalassemia screening test called HbA2. That is, we know normal hemoglobin is A2, B2, 2 alpha chains and 2 beta chains. While thalassemia is 2 alpha and 2 delta chains. So HbA2 more than 2.5 is thalassemia beta. Patient has all features of low hemoglobin, normal RBC count, low MCV, but HbA2 is normal. Then indirectly we say that it's probably suffering from alpha thalassemia. We have no test to do for alpha thalassemia, but absence of normal HbA2 with low hemoglobin and low MCV. Hemoglobin is RBC count is 4 to 4.5 and MCV is again 60. But HbA2 is 1 or 2%. Well, we are surely patient has got alpha thalassemia. Whether it is alpha thalassemia or beta thalassemia, there is enough of iron because the iron is always recycled in the body. What is not recycled is folic acid and B12. So these are the patients who need only reassurance and folic acid and B12. Right? Very, very important. So when we look for the peripheral smear and when we look for the RBC indices, the microcytic anemia, the most important diagnosis remain iron deficiency anemia, thalassemia. If the hemoglobin is low, but relatively the RBC count is normal. MCV is not very low. MCV is less than 78, but maybe 74, 70, 68. And then definitely it's more likely to be iron deficiency. Go for transparent saturation or maybe serum ferritin also if there is no infections or inflammation. Thalassemia, we need to go for HbA2. Pathologists might help us by additional information like basophilic stippling, right? Chronic inflammations, iron is low, SIBC is low, but as I said, ferritin will be high and transparent saturation will be high. So that is why this 20% transparent saturation is very important. Transparent saturation higher with high ferritin, even if the iron is low and SIB is low, we can say it's probably chronic inflammations. Of course, we have got to correlate with the clinical features, but this is how we differentiate different types of microcytic anemia, iron deficiency anemia, thalassemia, and chronic inflammations. Macrocytic anemia, always the peripheral smear would help us, right? We can always go for the estimations of B12 and folic acid levels in the blood. We need to rule out the liver functions, thyroid functions. And then probably the bone marrow is the only answer to whether we are dealing with megaloblastic anemia or myelodysplastic syndrome, where we expect the macrocytes to be macrocytic anemia. We know the hyperproliferative, that means the patient has anemia and the retic count is more than 2%, either it is blood loss or hemolysis. Blood loss is very obvious most often, but if not, we have to go for the stool for the occult blood test. That is probably the only one which is not obvious. Otherwise, most of the blood loss are very obvious. This is very important. Whenever you are suspecting hemolysis, we should run few tests, not necessarily that each and every test will do each and every patient, right? But when we are suspecting hemolytic anemia based on anemia with no obvious blood loss, anemia with high retic count, if these are the two situations, at least look for the LDH or look for indirect bilirubin. This is an hemolytic anemia, which is hemolytic jaundice with unconjugated bilirubin. So liver parameters like SGOT, SGPT will be normal, but bilirubin will be high. And if you go for the differential bilirubin, direct, indirect bilirubin will be high. So here is a patient who has got anemia, tinge of jaundice, bilirubin is high, 3 or 4, but it's mainly indirect, and the enzymes are normal. LDH may be high. If we suspect G6PD because patient has used certain drugs like chloroquine or primaquine or sulfur nitrites, and he belongs to a particular communities, maybe we think of G6PD, then go for G6PD quantitative assay. One important point, in most of our Indian patients, it's usually a quantitative deficiency, not qualitative deficiencies, right? So most of our patients have slightly lower G6PD values rather than absent G6PD, which is seen in Mediterranean variety. But important point is when the patient has hemolysis, the RBCs which has got less G6PD are all destroyed. And most of the RBCs are having. So we may have falsely normal G6PD level. So when we suspect G6PD, do not do G6PD assay right at the time of hemolysis. We have to do it after some time. At that time, we can only think of hemolytic anemia and by the certain other test, and keep in mind and go for G6PD after some time, right? Coombs test, when you are suspecting autoimmune hemolytic anemia, you go for the Coombs test. When patient has got dark urine, cola-colored urine, and the urine microscopy do not show any RBCs. When the patient has dark urine, hemoglobin, red urine or cola-colored urine, and if the microscopic urine examination does not show any RBC, then we think of hemoglobinuria and send that urine for the spectrophotometry, and it will pick up the band of hemoglobin. When we are suspecting hemolytic anemia, right, and patient has very high ESR, anemia, bone pains, we think of disease like multiple myeloma or monoclonal gammopathies, go for hemoglobin electrophoresis. We don't do this haptoglobin test usually. Haptoglobin is a protein which carries the free hemoglobin. If there is hemolysis, the RBCs are released, then hemoglobin is released. This hemoglobin iron are very, very toxic. That has to be removed, and that is done by the protein called haptoglobin. So haptoglobin will consume the hemoglobin, take it to the liver, and that get disposed. So if the haptoglobin is less, again suggests that we are dealing with hemolytic anemia. It's not routinely done, but worth doing that there is something like haptoglobin which will be reduced in hemolytic anemia. The further investigations depend on the cause, and as I said to begin with, this is not something order in which I would go for the test. I would go for creatinine in all patients right on day one with the normal test at a consistent levels. After CBC, retic count, urine and stool, my first investigation will be creatinine in blood urea. Right? As Dr. Pragnisa also said that acute kidney injury or chronic kidney injury are something we miss in patients of anemia. That is true. We always go for, keep in mind, creatinine and urea. If the creatinine is high and the urea is normal, normally the urea to creatinine ratio is 40 to 1. 40 urea and creatinine 1. The creatinine is say 2 or 2.5 and the urea is only 40 or 60. Probably we are dealing with chronic kidney disease. And vice versa. If the urea is 100, the creatinine is only 1. Probably it's a pre-renal or acute kidney injury. Patient has a pre-renal cause of acute kidney injury. That's different. Go for sonography if you are suspecting that patient could have chronic kidney disease. Protein electrophoresis we already touched upon. Any patient with very high ESR, anemia, bony pains, or peripheral smear indicating something like plasma cells, we go for the protein electrophoresis. Barium studies endoscopies when we are having an obvious blood loss which is in the GI. Bone marrow is an invasive test. We should be reserving it for very, very select patients. So, to conclude, anemia is a very common problem, and as I began with, anemia is not a complete diagnosis, it's an incomplete diagnosis. Whenever we think of anemia, at least we should have cause or causes of anemia and the type of anemia for a complete diagnosis. History examinations would help us to get to some diagnosis, but the most important questions remains CBC, ESR, PS, RBC indices, and retic count. Retic count, I think I would stress more than overemphasize, you may feel so. Then specific investigations like iron, mainly transparent saturations, levels of B12, folic acids are important. And test of hemolytic anemia, it's worth keeping in mind and go for an individual test like Coombs test or G6PD protein electrophoresis. Bone marrow is reserved for few patients. Thank you very much. And forum is open for any comments and questions if there are any.
Yes, there is one questions
Yes, sir.
that I received from
Sure, sir.
one doctor at Baroda, that
Yeah.
which form of iron, oral iron, should be preferable in children, pediatric age group?
Pediatric, I'm not the right person to answer probably, but usually, as I understand in adults, we say that the one which delivers the maximum iron is ferrous sulfate as such. But it's a problem is of tolerance. So that is why people use the ferrum gluconate or ferrous fumarate, right? I'm not sure about the type of preparations that patients, I mean, so pediatric age group patients, if any pediatricians available would be to say, but I think they use ferrous fumarate or ferrous gluconate only. I'm not very sure, and I'm open to corrections.
So I would like to congratulate you, sir. It was an excellent, exhaustive, very informative, and
Thank you.
did lot of justice to the topic approach to a case of anemia. How do we approach?
Right.
Thank you
Yes.
very much, sir.
Although treatment part is not covered, but the way of presentation, how to diagnose different types of anemia. May I know, Mahadev, clinically, how can we differentiate hemolytic anemia?
As I said, the hemolytic anemia, yeah. See, at the back of the mind, we should know what are the causes of hemolytic anemia. The acute one is usually G6PD or mismatched blood transfusions or malaria. The hemolysis can be extravascular, intravascular, right? So mismatched transfusion, they are intravascular. Malaria is also intravascular, but hemoglobinopathies are usually the extravascular type of hemolysis. So over and above the symptoms of anemia, that is fatigue, tiredness, pallor, if the patient has something like hematuria, if the patient has the dark colored urine, or patient has got the yellow sclera, right? These are something which would always point towards hemolytic anemia. And the history of drugs, after drugs, patient has after food, a patient has it. Or as I said, patient has joint pain, right? The joint pain may indicate towards the sickle crisis or painful crisis of the sickle. So I think there are many pointers to the hemolysis. And as I said, the most important instrument after CBC is retic count. If the retic count is high and no obvious blood loss, I would like to investigate in the line of
10 minutes. Sir, there's a question. Which salt of iron is ideal to treat anemia?
In adults, we usually say we start with the ferrous sulfate because it is the most commonly available and probably has the highest absorption. But any salt which the patient tolerates can be fine. Now we have got many iron salts are available. My preference always remains with the ferrous sulfate, but ferrous gluconate, ferrous fumarate are also fine. And people have also added vitamin C, but practically iron deficiency anemia, there is something what we have been told in physiology is called Lyon's hypothesis, that body will absorb. If there is deficiency, iron absorption itself will be high. If there is no deficiency, whatever iron we take, we cannot develop iron overload by taking oral iron, because the absorption is related to the hepcidin. Hepcidin is a hormone which is a master regulator for the iron. only when there is iron deficiency anemia, the hepcidin will go down. Otherwise, hepcidin is a hormone which remains high, and that will prevent, that is a switch for iron absorption. So whatever salt, whatever additional vitamin C, the only thing is when we are giving iron, better avoid milk, antacids, or food, so that the iron can be absorbed better, because it's because of the combinations within the stomach that will not prevent the iron to be available. That's it. Otherwise, I don't think any way we can increase the iron absorption other than taking it on empty stomach and avoiding the food with it.
So in
Problem is more of tolerance. Yes, ma'am.
So in your experience, what about the side effects of the different salts? Have you seen less side effects with fumarate or gluconate?
I don't think, madam, there is much of the side effects. Some side effects are mainly the GI intolerance and
GI
constipation.
intolerance.
Constipation is really universal. It's all salts. And the recommendations, even the textbook recommendation, is start with a smaller dose. We use preparations which has got 50 milligram of elemental iron. Most of the iron is 150 to 300 milligrams. So we start with something which is a semi preparations. I would not give the name of the trade name, but
fine.
we start with something like 50 milligram of iron, or we tell them that start taking on alternative fast. And if it is tolerated, we can make it one full tablet daily, or the dose can be up to 3 tablets of iron if the patient can tolerate. The ideal, if the patient has a severe iron deficiency anemia, and if the patient can tolerate, we have given 3 tablets of ferrous fumarate or ferrous sulfate, and patients have tolerated it. But important thing is that nowadays the iron parenteral preparations are so safe that we more often use parenteral preparations in our consultant practice. Particularly the FCM, ferrous cyto maltose, right? Ferric cytose maltose is very, very important. FCM, we very easily prescribe. All that we have to give is a one single parenteral infusion over a period of 15 to 30 minutes. Parenteral preparations are so safe that yes. Use parenteral preparations in our consultant practice. Particularly the FCM.
So there is a question: anemia of chronic kidney disease and role of erythropoietin.
I think there is a role of erythropoietin, but it's more with the nephrologists, right? We always treat in consultants with the nephrologists, but definitely there is a role of erythropoietin because that is one which is deficient, and it helps in correcting the anemia more than any other way we can treat it. Even if the patient has simultaneous iron deficiency anemia, we can give parenteral iron and erythropoietin. Only problem with erythropoietin, it can increase the blood pressure. So that is what we have to keep in mind when we are treating the patients with erythropoietin. But erythropoietin is very well accepted treatment, and now there are so many different brands are available and different preparations are available for it.
So there is another question: if hemoglobin is normal and ferritin is low, then what do we look for?
Of course, patients, many times the patients have symptoms or findings before. Patient may not have symptoms or hemoglobin, but this is probably the subclinical iron deficiency anemia. And if the transparent saturation is low, I would try to look for any obvious, some occult clause like whether there is any worm infestations or whether there is any, mainly not ferritin, of course. If the patient ferritin can be low because of the storage problems, right? But or maybe patient has chronic liver disease and that is why the ferritin is not produced. But if the iron is overall low and the transparent saturation is on the lower side, the most important is transparent because that is the one which transports the iron. So if the transparent saturation is less than 20%, I would be treating that patient with iron preparations. And see, many times we have seen the hemoglobin is almost normal, and patients complain of fatigue. And we start iron and patients start feeling better because at the molecular level, because of the iron deficiency anemia, patients had symptoms of fatigue and they feel better. Even there is no obvious increase in the hemoglobin immediately, but patient will start feeling better very fast.
So what is the indication or when do we start in parenteral iron?
So, parenteral iron, I think that's a very, very important pertinent questions. The two most important to me is one, if the patient has got pregnancy and anemia, pregnancy, otherwise also the tolerance of most of the oral medicines, right? And we have to ensure that the mother and the fetus both receive enough iron. So that is one place where we would definitely be giving. And second important is patients having congestive heart failure or ischemic heart disease, or patient has undergone any procedures and blood loss, and that we need to replace iron because nowadays anemia as one of the important cause of the heart failure or one of something which we can treat. So these two conditions we would definitely give parental iron. But I would also add the patients who come from far places or patient who is ill-rated, patients who is where we are not confident that you will be completing the oral iron. I would straight away go for iron therapy.
How do you calculate the dose, sir?
Of course, there are the formulas, but I don't think that we, of course, theoretically, we know that the weight of the patients into multiplied by patient's actual the target hemoglobin minus the actual hemoglobin. If the patient's weight is 60, what we want is say 14, and his hemoglobin is say 10. Say the difference is 4. So 60 into 4 into 10 plus the storage value, that is 500 plus into 0.24. This is the formula. Weight in kg into normal hemoglobin minus the patient's hemoglobin, right, into 10 into 0.24 plus 500 as a storage. Roughly, it would come to maybe around anything we round up to either 500 or 1000. What we give is 500 milligram to 1000 milligram at one go. We do not give more than 1 gram in a week. And so 500 milligram to 1 gram we give, and next week we call the patient again. And if required, we'll give one more dose. Generally, we give 2 grams, not more than 2 grams. Usually required is sufficient in most of the patients.
So how can iron and calcium be given?
preparation.
Yes. Yes, yes.
Yes, sir.
For parenteral preparation, there are different salts available, and
Right.
as per salt, we have to give. So I think treatment part will remain today.
Right.
And
No, my point was
I will
general,
be,
Dr. Sanjay. Dr. Sanjay, generally is
Yeah.
that you see most of the parental preparations are either they are available in 100 milligram, right, or 500 milligram.
yeah,
So depending
Right.
on what you want to give on an OPD basis, right? Usually we give if
Yes.
one shot because we don't want patients to come again and again. So 500 milligram, obviously the deficit when the patient is deficient, that means even the storage of 500 milligram also not there. So minimum that he needs would be around
Yes.
1 gram or at least 500 milligram. Right. So that was the point.
Yes,
But
yes.
I agree with you that it's available. All that you have to see is whether we put 1 ampule or 10 ml ampule or 5 ml ampule, 10 ampule, something like that. But the average dose remains in 500 milligram to 1000 milligram per session.
Yes.
So there are many comments. There are many comments, and everybody has appreciated your talk. Very interesting and very, very informative talk,
Thank
sir.
you, madam. Thank you.
Yeah,
I also enjoyed discussing.
Yes, sir. Thank you so
Yes.
much.
Thank you. Thank you, sir.
Dr. Sanjay for
And, yes, we are also thankful to Sun Pharma for giving sponsorship for this program. And thank you, Mahadev. Really, you have taken a very nice lecture, and we family physicians will be definitely appreciate you, and it will be knowledgeable to in our practice also. Thank you, Mahadev.
Thank you.
sir.
Thank you. Thank you
Thank
for
you,
the
sir.
invitation.
Looking forward for more.
Sure, my pleasure. Yeah.
Yeah, I'd like to introduce Dr. Manju. Open your video. This is Dr. Manju Soneja from Bangalore, sir. She is also an active practitioner. Manju? She's not there, I think. Okay. Thank you very much, sir. Thank you,
Thank you.
all the participants.
Thank you. Thank you.
Thank you, Dr. Jagdani. Thank you, Rushil. Thank you.
Hello.
Okay.
Yes.
I
Yeah.
was just having some
Manju
network
Soneja.
glitch.
Manju Soneja
Yeah,
from
good evening,
Bangalore.
sir. Good evening, good evening. It was
Good
an
evening.
excellent talk, sir. Thanks a lot. Learned a lot. Lots of insights.
Thank you.
Thank you,
sir.
Dr. Preeti. Thank you, everybody.
Thank you. Thank you, Dr. Sanjay. Sushil, you can end the meeting.